Hi all, thanks for having me. I'm an emergency physician, and my focus is on ultrasound in resource-limited settings. Today I want to talk to you about how I think point-of-care ultrasound has a transformative effect on not only patients, but also providers in resource-limited settings. I was asked to talk about global ultrasound relief today, and in thinking about that, and as you heard this morning, ultrasound is obviously very helpful in extreme environments, and I think in my practice in disaster field hospitals and Ebola treatment units, but nowhere have I seen ultrasound have more of an effect on patient care and outcomes and save more lives than the hands of trained practitioners on a day-to-day basis in contexts where resources are otherwise limited, like the developing world. These are settings where patients are more often coming to care, already critically ill, and where there's not necessarily a natural disaster or an Ebola outbreak that's causing resources to be constrained, but that's how they're practicing on a daily basis. These are the real force multiplying practitioners that I want to discuss with you today and introduce you to a few of them. Even in settings where patients are coming where they don't know that they're ill, where they're coming for routine antenatal care, for example, in a context where they might otherwise deliver at home, the ability of practitioners to use ultrasound in evaluating those patients can help diagnose major potential complications, things like placenta previa or multiple gestation, maybe even triplets, which we seem to have a real penchant for finding on ultrasound. It scares me to think that if I was a mother on Pemba Island in Zanzibar last year, I wouldn't have any access to antenatal ultrasound. And this large, asymptomatic fibroid that's obstructing my cervix would not be diagnosed and may likely result in obstructed labor and an outcome I wouldn't want to think about for myself or my baby. Now we have a training program in Zanzibar. We partnered with the Laerdal Foundation and with UNICEF to acquire equipment. And we have trainees like Fatma who are using ultrasound on a daily basis, scanning hundreds of patients to help identify potential complications that might indicate delivery in a health center or referral off the island for a higher level of care.
My name is Fatma. I'm a nurse midwife from Pemba Island. I have scanned many pregnant mother, and I found many cases like molar pregnancy, placenta previa. I found a free fluid from mother with severe eclampsia and a mother with ruptured ovarian cysts. This ultrasound helps us to save many lives of the mothers and the unborn fetus.
This is Gavin. He's one of my first trainees back from 2013, and he has since taken the basic ultrasound training that he received. For example, in cardiac ultrasound, he's now doing a ton of advanced applications on a daily basis, diagnosing wall motion abnormalities, valvular issues, TB effusions, masses, and has become a major resource in not only his emergency department, but also his hospital and, frankly, the health system.
Cardiac, I do find that cardiac makes a lot of difference. And we don't have so many cardiologists in the country. In the hospital I work in, we have only one cardiologist and another one that is visiting. So we only have literally 2 cardiologists. And by doing cardiac sats, it's one of the things that you can easily do and get a lot of change. And you can easily change management around here. So cardiac science I do quite a lot, since nobody else will be doing that.
This is the emergency medicine residency in Rwanda, the first to exist there, of which Gavin is a part. In the center picture there is Olivier. He's one of the chief residents there. This is a context where ultrasound was actually integrated into the residency training program before it even began. So these residency trainees are actually using ultrasound not just on a daily basis, but for pretty much every patient that comes into the emergency department, due to the lack of portable X-ray and inability of patient to pay for other imaging, which may or not be available in terms of CT scan and other. Olivier is going to tell you about one case of an undifferentiated patient, and this is just one example that they're seeing on a daily basis.
We are seeing many patients on which ultrasound is really helping a lot. But the last time I remember a young man, they brought him here, and that young man has some sort of altered mental status, agitated, but young, but no one knew what was going on. And I remember that after doing taking a history, which was not very good because he didn't have a caretaker, but then we did a thorough physical exam, but then we did an ultrasound. And actually, the ultrasound made a difference because we ended up finding that that young man had infective endocarditis with vegetation on the valves, and then he was throwing septic emboli into his legs, and that's why he had some sort of monoplasia. We found actually he had an ischemic limb, and later on the CT scan showed that patient also had a stroke, ischemic stroke. I think that ultrasound made a kind of difference in making the diagnosis for that young man.
So obviously there are changes to initiating these types of to initiating these types of training programs, including resources to get training started and equipment, and particularly maintenance of equipment in tough conditions. But I think focusing on the bright spots and trying to amplify those is really important in terms of developing trainees like this. Because I can tell you, once they have the ability to train in their setting, they're trying to develop and answer locally relevant research questions, the impact is huge. I think the proximal goal is having our trainees taking over with the teaching, like Jean Pacifique here, for example.
These are really our spaces, our what we are going to cover. It's like a kind of summarizing what we come to see progressively. The first space is subcyphoid space. This is how we call it, where it will help us to visualize the pericardial space. Up the diaphragm there is what? There is a pleural space. Why do you say that there is collection? Why? There is no? There is no? Okay, I want you to repeat it. There is no Myro? Excellent.
You can tell he has a lot of enthusiasm for teaching. So the process is long, and I think that from our trainees being teachers, the idea is hopefully for them to evolve even further from that. And I think Jean-Paul is a great example of that. He's a surgeon who initially started training with us in 2013, did a Train the Trainers program, and then developed the idea for a study evaluating pneumothorax by ultrasound compared to chest X-ray. And he trained his co-residents actually for 4 hours in pneumothorax ultrasound and compared this to expert interpretation of the ultrasound as well as chest X-ray interpretation by other residents or by radiology, and found actually they were 100% sensitive by ultrasound for pneumothorax, but only 55% by chest X-ray. So this obviously brought up a bunch of challenges and considerations for their curriculum in terms of the need for them to have better chest X-ray training, but also the ability for them to rapidly acquire the skill of diagnosing pneumothorax by ultrasound, something that's available in their setting and now being further incorporated into their practice. Vicky Noble once told me that ultrasound is the universal gift. And I think that our trainees are certainly finding that to be true and really becoming indispensable in their practice. Olivier is going to tell you a little bit more about that.
I can tell you from my perspective, I don't know what would our department become without an ultrasound machine, because ultrasound is something we are using a lot. When we started, we didn't knew that ultrasound will actually help us as much as it is doing. But nowadays, all our residents, all our doctors are being trained thanks to Pure also helping us in that training. And then we think in the future, we see how we can put some formal training in point of care ultrasound, because our settings are limited in terms of having every specialist you need. To find a cardiologist is not something you find very easy as you wish. but we are making a big difference by using our skills, and especially taking critical decisions, deciding whether you have to give fluids to a patient or whether you have not to give. So it's something ultrasound has become already kind of paramount for us.
So I think this is the longer term goal. This is Olivier last week with me in Boston, actually teaching my ultrasound fellows about ultrasound and his practice and care in his emergency setting, while also learning about the care in both our ultrasound division, our emergency department, and the health system in the United States. And I think this is where the future is. I think thinking more about bilateral partnerships in terms of not only education, but also mentorship and research collaborations can be of global benefit. I think it's important to think not just about necessarily picking up your ultrasound and responding to an international disaster, but trying to get further involved in capacity building efforts like this. So thank you very much for having me.